Okay, welcome everybody. My name is Bridget Richards. I am the current outgoing chair of the College of Gerontology Nursing for NZNO. I'd like to welcome you all to joining us today for this symposium. Unfortunately, we were hoping to have met you all down in Wellington over the last couple of days, but as we all know, pandemics have come in between, so hopefully we will be able to give you some updates on some interesting speakers today. In terms of how today will run, we have a number of guest speakers throughout the webinar and our biennial general meeting also to complete. At the bottom of your screen, you will have three buttons. There's the chat, the raise hand, and the Q&A. For questions for our speaker Q&A, please only use the Q&A function. Type your question into the box and hit enter. If you see a question which you like or is similar to what's going through your own head, you can upvote it by clicking on the little thumbs up button. So that will raise it up in the order of importance if more than one of you have indicated that as a question. If we run out of time with the individual speakers and we don't get through all the questions asked, we will get these addressed and send them out to you after the event's finished. The raise hand will be used in our COVID discussion session in about 15 minutes time. If you wish to speak, raise your hand and then wait until a message on your screen appears to unmute your microphone. Only your photo or name will show on the screen. You ask your question, and once your question has been asked or completed, you will be muted again and the next person will be able to speak. Please be patient. We do aim for everyone to have their say. If you change your mind, you can lower your hand. The BGM will use the raise hand function again. And if you wish to speak, please be assured everyone will get an opportunity to speak if you raise your hand and unmute your microphone when requested. So the chat function will only be used during the BGM. Please just drop down to the chat box now and check that the option you have to send the message is set to all panelists and attendees. We will provide further details on how the BGM will run a little later on. So for now, please ensure you use the Q&A box for any questions for our speakers. Okay, so I'd now like to introduce you to our first speaker, Morag McKenzie. She is the Senior Academic Staff Member at the Centre for Health and Social Practice at WINTAC and a committee member of the College of Gerontology Nursing. Morag is going to present to you our updated knowledge and skills framework for gerontology nursing.
Wonderful, thank you Bridget, and welcome everybody. It's lovely to have you on board here this evening, and as Bridget said, it is a shame that you couldn't join us in Wellington, but hopefully in the next year or so. So I'd just like to start off briefly with an introduction about me. Ko Ben Van Tamonga, ko Apple Cross Te Awa, ko Mackenzie Te Iwi, ko Cummingston Te Marae no Scotland Aho, ko Morag McKenzie, toka whenua. As Bridget said, I'm a Senior Academic Staff Member at WINTAC and a very proud member of the National Committee of the College of Gerontology Nursing. We'd like to be able to share with you and present to you some information that we have been working on in the last little while, and the knowledge and skills framework will certainly be available for you, and hopefully this PowerPoint presentation as well too. But before I go any further, I'd really love to draw your attention to that beautiful photo by Antoinette Baker on the left-hand side. And I think that really epitomises that intergenerational viewpoint that we are here to support as well. And Antoinette is in fact a local photographer here in Christchurch. So beautiful work, Antoinette. Next, please. So the Knowledge and Skills Framework was established or developed by the College of Gerontology Nursing, And it was really all about supporting nurses in their own professional development. And it was to ensure that we had experienced and well-trained gerontology workforce. And it was also about underpinning our vision for being visible and valued. So this was developed in a much bigger format, probably around about 5 or 6 years ago. But we really felt that although the document was extremely comprehensive, we really wanted a newer look and perhaps more user-friendly version. And our chairperson, Bridget Richards, came upon the 5 M's, which we're going to share with you as well, which has underpinned the knowledge and skills framework that we have available for you. Next, please. The college has utilised the geriatric 5 M's, and this is a simplified communication framework to describe what we consider to be core competencies in geriatrics. Or older person care, perhaps is what we really refer to here in New Zealand. This was developed by Frank Molnar and Alan Huang from the University of Ottawa and Mary Tinetti from Yale University. And we are very grateful for their kind generosity so that we can utilise all their hard work, but also look at it from a different perspective here in New Zealand. And we'll be sharing that back with Frank and Alan in a short while. So we've looked at how can we best utilise the resources that we have in a quick, easy format. And this is available through the College of Gerontology Nursing homepage via the NZNO website. So if you are a member, you'll certainly be able to access this. And we've combined a number of resources, including areas of interest, professional development, through links on our website. So you will certainly see that as we go through the next couple of minutes. Thank you. Next, please. To access it, it is just in the left-hand menu, which you will see on the College of Gerontology Nursing website. And it starts off with using the hand and the 5 areas of core competencies. And what matters most is focuses on individuals' goals and ensuring that it underpins and supports the strategies that we have in New Zealand. So it's really that foundational information to provide quality of care. So in this particular section, you will find links to vital strategies such as the Healthy Ageing Strategy, the Māori Health Strategy, New Zealand Disability Strategy, as well as links to organisations such as ACC. And it covers not only funding and other supports that are available in strategies, but it discusses some legal aspects as well, such as advanced care planning and enduring power of attorney and finances. So that is something I think you will enjoy looking through those links there and discovering the information that is available for you. Next, please. The Mind section looks at, in particular, resources that discuss depression, delirium, dementia, mental health in general. And it's broken up into sections such as information-specific material or resources, and we have training or professional development opportunities. So we have set links through to other areas that you can access and continue your professional development there to assist you with that understanding of care and that for that aspect of older people. Next, please. Mobility, staying mobile, is a key component of independence, and we have utilised these resources here once again in a practical aspect, such as providing falls information, even links to Tai Chi, green prescription. We've discussed and have links for you for about maintaining that independence with mobility for the people that you care for, including even things like the total mobility scheme. And a question that is asked very frequently about ambulance transfers and the cost of them. So we try to provide a variety of information for you, but also some practical components in your day-to-day care that you have. Next, please. The knowledge and skills framework is certainly touches on some key aspects of our care when, from a nursing perspective, and that it's looking at polypharmacy, deprescribing, adverse reactions, and we've provided for you in the knowledge and skills frameworks and best practice guidelines. So we have items such as opioid conversion charts, reducing harm with medication, medicine care guidelines, and as I said, best practice. And our last little finger here, which is by no means little by any means, but is the multi-complexity. And I think it's so important to acknowledge that the people or older people that we support are often very, very complex in their health needs. And we have endeavoured to put into this particular section a variety of information that I think you will find beneficial, such as managing people that have multi-complex health issues. We've also included relevant interest groups. We've included areas such as the Health Quality and Safety Commission, which has an incredible wealth of resources there. We talk about management and legal aspects, family, social, cultural, lifestyle, and family and cares. So I do feel that the 5 areas that have been covered by utilising the 5 M's will be an excellent resource for you as practitioners, so that you can user-friendly, quick, have a look at the resource and discover, I think, some areas that are important for your day-to-day practice. And just lastly, we've got our last page there. Next, please. We invite you to have a look at our knowledge and skills framework, and please provide us with feedback, because we're very aware that it's not an exhaustive list and we may well have missed some. So we certainly would like you to contribute towards that, and it will end up, I feel, being a resource that we can all be proud of, and we certainly are proud of what we've done today so far. But this is about you and your learning and your professional development. So if you have any areas or you note any resources that you would like to share with us, then please use the comments section, which is just on the right-hand side menu. Drop us a line and we will have a look and we will include that in there. So that's all from me. Thank you. Enjoy looking through them. Thank you.
Thank you, Maura. Is there also a comment about how well we're keeping it live, and are the links being checked regularly? So
yes, they will be. A good question. There's nothing worse than finding a website with dead links and 404s coming back at you. So the website is in fact managed through NZNO, and part of their role is to ensure that those links continue to be live. And if we do note any that have expired or changed, we will certainly be finding that information for you again.
So questions just come through. What is the website? Sorry.
Oh, right, no, good point. So this is the NZNO website, and on the website we have a number of colleges and sections, special interest groups. So as a member of NZNO, I believe it's 2 sections you can belong to, just looking, three sections you can belong to, there we go. So one of the sections that you may wish to join, college, sorry, thank you. We now have college status, which is very exciting. Sorry, just corrected me. So you can join the College of Gerontology Nursing. So that will be a link that you can click on, and then you will have available to you a number of resources, including the knowledge and skills framework. Okay. Lovely, thank you.
Thank you, Maura.
My pleasure.
Wonderful, succinct presentation.
Thank you, Bridget. Everyone enjoy. Go on and have a look.
Yes, it's not exhaustive, but it's pretty comprehensive.
Yeah, I think it's a good start anyway. I think collectively together we can just keep improving.
If you know of any resources that are not on there, please let us know. Thank you, Maura. Okay, we'd now like to take the opportunity to spend a few minutes acknowledging the impact of the COVID pandemic on our members, their families, residents, clients, and also their colleagues. We've all got our own stories and perspectives of this time, and as part of the conference we were planning to allow people to have an opportunity to raise any issues or concerns that they had, or stories of good practice or stories of things that haven't gone so well. My personal story is as a nurse practitioner covering a number of rest homes within the Waikato region. I got caught up in the SEC cluster, which was quite early on, and I was actually stood down from work for 2 weeks. Didn't have to swab, but suddenly my normal working routine was totally changed, and we needed to get into the Zoom and Facebook connections and phone connections and doing telehealth consultations very, very rapidly. Fortunately, we didn't lose any residents or staff during that particular cluster. However, some staff members were extremely sick, and it's taken them a long time to come back to work. So is there anybody else who would like to share any comments or experiences over this time? I'm currently on a Ministry of Health working group looking at pandemic planning across the aged residential care sector. So if there's anything that you feel should be addressed, then potentially we can take that back to the group. So use the raise hand or Q&A functions. It's a little note from Paula. How about you, Morag? How did life change for you during the pandemic?
Well, we certainly we have a hybrid way of teaching at Wintec, and we have a significant amount that is online as well as mostly face-to-face, but certainly it meant for us that we needed to increase our online presence. Pastoral care in particular was particularly of importance for our students who were juggling a variety of changing worlds as well too. You know, some of them were essential workers, some of them were now managing full-time childcare as well as trying to continue to study as well as trying to work. And it's been particularly problematic, and we have a number of students out in practice now, but many students have had their educational, their clinical placements delayed because of it, and that has caused, I think, great concern as well for them too. But it certainly has been a very difficult time for everybody.
Yeah. So, is there any questions? No. I think that what I saw was an incredible amount of resilience amongst the care workers, especially, and the challenges that occurred when a large number of the staff group were actually also stood down, and suddenly residents were confronted with people they didn't know in PPE who didn't know them, and residents were also all isolated to the rooms. And I think that seeing now a few months later, we can see that there was a decline in the general health of those residents at that time, although they didn't become ill with COVID. So do we have a question somewhere?
Shireen's going to be brought on live.
Okay. Welcome, Shireen.
Hello.
Hi.
Oh, hello. I can see me and you.
Glorious Technicolor.
Yes, we can.
I guess our question is because of what we have been researching, Annika and myself, several of the residents that we've spoken with in the second part of our research has been that they felt that they weren't consulted when all the lockdown measures happened, and of course it was unprecedented really at this time. What are your thoughts, and what do you think is going to change going forward if there are more cases and suddenly we need to go and increase our lockdown measures? What have you got sort of on the horizon for people who don't want to be in lockdown, like who would rather have COVID than not spend time with family?
Oh,
It's a curly one, isn't it? But a very valid question, Shireen. Absolutely.
a lot of the extra precautions that have been taken over the last few weeks with the second outbreak, if you like, were led a lot by the NZACA as providers within the aged care sector. And they were looking after their business, rightly. They have to ensure that they keep the confidence of the public and the residents and their families. But like you say, it's where's the rights of the resident within that to actually not have to be locked in? Very tricky. I'm not sure I'm the person to have the answer, but it is something that the Ministry of Health pandemic plan is being asked. Both myself and Marg Bixby, the PNA, are trying to ensure that that voice of the patient is still heard. So yeah, residents not being consulted, collaborative approach.
Which is what has occurred in other areas as well too.
Yeah.
Thank you.
I'm not sure what that question means there.
So this is from another person's perspective in the room here on the committee. So that there was a significant collaborative approach with family and residents, and some increased communication there. So I think different areas obviously would have had different approaches as well too, but I'm sure also that there were a number of, oops, must be my time's up, did you hear the train? A number of facilities have certainly supported with the collaboration with the residents and families, increased communication, and also open and transparent in information and sharing. So certainly very interesting from that perspective, and a great question. And I think there would have been a number of approaches from a variety of different residential care facilities across the country.
Is there anything else? No? Okay, well, we'll move along. We're now going to hear from Professor Brendan McCormack. Brendan is currently the head of the Division of Nursing, Occupational Therapy and Art Therapies, the Associate Director for the Centre for Person-Centred Practice Research at the Queen Margaret University in Edinburgh in Scotland, and he's the Honorary Nurse Consultant for the Erskine Care in Scotland. He also holds adjunct professorial positions at universities in Ireland, Norway, Slovenia, South Africa, Austria, Denmark and Australia. His research has specifically focused on person-centred practice, and over a period of 22 years, he has developed models, theories, frameworks and evaluation instruments that have been adopted globally in policy and practice. In addition, he has led the implementation and evaluation of person-centred practices in a variety of clinical settings and in healthcare curricula. He has particular expertise in gerontological nursing and the adoption of person-centred practices with older people. The impact of his research in person-centred practice is far-reaching, and his work has been adopted in more than 28 countries. He has more than 600 published outputs, including 210 peer-reviewed publications in international journals and 12 books. I can assure you he's quite a good speaker as well. He's the Editor Emeritus of the International Journal of Older People Nursing, a Fellow of the American Academy of Nursing, the Fellow of the European Academy of Nursing Science, Fellow of the Royal College of Nursing UK, which is where I met him many years ago, and a Fellow of the Royal College of Surgeons in Ireland. In 2014, he was awarded the International Nurse Researcher Hall of Fame by Sigma Theta Tau International and listed in the Thomson Reuters 3000 most influential researchers globally. So, Brendan had originally agreed to present at our 2-day conference, which we were very excited about. We were using the May the 4th Star Wars technological advances with being able to zoom him in from overseas. So he has sent a video through in advance. He is going to join us at about 10 to 7 for a live Q&A session. So just a reminder, the Q&A session, use the Q&A function at the bottom of your screen. Please put any questions you have in this box and we will direct these questions to Brendan to answer at the conclusion of his presentation. We will only take the questions via the Q&A box. Do not use the chat or the raise hand function for this next part. Remember, you can upvote someone else's question. Just use the thumbs up button by the question. So here we go, Brendan's presentation. What?
Good evening, everybody, and thank you for asking me to do this talk in lieu of coming to the postponed conference from the College of Gerontology. I'm delighted to be able to talk to you in this way, and even more delighted that I'll be able to engage with you after this in a Q&A session. I was asked to talk about person-centered practice, which I'm delighted to do, but to also talk about it in the context of gerontological nursing and what's been happening around COVID-19. So what I want to do in this time that I have is to talk a bit about what person-centeredness means to me in the work that I'm engaged in, some of the issues that have arisen during the COVID pandemic, and maybe some ideas about what I think we need to be doing as we move forward in gerontology collectively. So person-centered practice is truly a global movement. It's no longer something that is an add-on to healthcare. It truly is at the heart of healthcare now. It very much informs healthcare strategies and global healthcare development. The movements like what's happened in the World Health Organization around it being part of their health systems work, being included in the Institute for Healthcare Improvement's work on quality improvement, as well as a whole array of other work that has now happened around the world to advance person-centered practice, has really made it something that is really at the core of most healthcare systems globally. But at the heart of person-centeredness, for me, is the notion of personhood. And I guess if I was to be critical of what's happened around this whole development, has been that a lot of what we see as person-centeredness happening in healthcare is quite superficial and very much at the level of particular practices or particular tasks. And I think in older people services and often in dementia services, I think this is a particular problem. So at the heart of person-centeredness for me is the notion of personhood. Who am I as a person? What is it that makes me a person? And if you believe in, if you have a religious faith, then you may see this as being about the soul and how the soul is shaped by that faith. If you don't have such a faith, then we may refer to it as self. What makes me more than the tissues that hold me together, the human brain that I am. But what is it that makes me different from an animal, perhaps, that makes me a person? And this is all about things to do with beliefs and values and desires and motives and how we make decisions in the context of all of that world. And the philosopher Leibling refers to this as both our interior and our exterior conditions. Our interior conditions being those beliefs and values and views of the world that I hold that shape my being and my doing, and the exterior conditions then being about the world itself and how we are interacting with it to shape what we're about. And so personhood is really at the core of person-centered practice and shapes every human being, every person. And so it's not just confined to person-centered care, it actually shapes the whole nature of person-centeredness itself. And in our work, we have argued, and we use this framework to argue very strongly, that if we are talking about person-centeredness, then we have to be really seeing it at a deeper level than just the tasks or the work that we do, because it is about the nature of our being. And we've identified 5 modes of being. Being self, which is about my values, who I am as a person, and being comfortable with that. Being in relation is recognizing that we all exist in relationships. And you may have seen in the literature a distinction being made between relationship-centered care and person-centered care, for example, a distinction that we would contest because relationships are such a fundamental part of being person-centered. Being in the social world reflects that we all exist to be social, that is the nature of our being. And so being healthy enables me to connect with other people in a social dynamic world. Being in place, the idea of both physical place but also metaphorical place. And for older people, place, of course, is such an important part of how they connect and how they live their life and feel content within their world. And being in time recognizes that we are all time travelers. Whilst I might be here at this moment in time, mentally I may be somewhere else, emotionally somewhere else. So we're in this constant state of becoming. My being right now helps me to know the next stage of my journey to become something else. So persons are never fixed, are never static. And of course, that is so important to when we're thinking about our work as nurses, because the person who we are providing care to or with today will be slightly different tomorrow or 10 minutes later because of the way their personhood is constantly in a state of becoming, and that applies to all of us. And so person-centered practice, therefore, is about the nature of our being. It's about these healthful relationships that enables my being to be realized in a way that respects me as a person. Healthful relationships are relationships that nourish me, they energize me. And so what's important about this, to recognize in this definition, is person-centered practice is not just about person-centered care, it's about everything that I do as a person. My relationships with colleagues, my relationships with managers, with leaders, and the relationships I have with patients, residents, or service users. And we would argue very strongly that in order for us to engage in person-centered care, we have to have a culture that embraces the same values of person-centeredness, that respects all persons as of equal worth, of equal value, something that I think is often overlooked in many of our health systems work. And that's because all persons need to flourish. Aristotle originally coined the notion of flourishing, but he referred to it as happiness, as a moral idea. And Aristotle also said that if I'm not flourishing, I'm languishing, and languishing is a state worse than death, which is a very strong statement, but really shows the importance of why we need to flourish as persons. Because when we are flourishing, we are at our best, we are giving of our best, and we are able to give and receive loving kindness. That is, we are able to connect with others in a loving way. And the Danish philosopher Løgstrup, I think, really captures how we help each other to flourish by the nature of our connections. And Løgstrup argues that it is our attitude, in a sense our moral attitude, our moral acumen, that helps us to do this, and that we hold a huge amount of power in our ability to do this. And of course, as nurses, I think this is really important to think about, just about the power that we have, particularly when working with older and perhaps vulnerable older people, about how we can shape the world. As Løgstrup argues, we can make that world big, or we can make it small. It can be drab, or it can be bright and rich, or it can be dull, or it can be threatening or secure. And of course, for older people, we know that a sense of security probably outdoes all other feelings and senses that older people need. Feeling secure makes everything else come alive. So when we think about what we're about as nurses, then my core function is to help me and others to flourish, for us to continuously be flourishing as persons. And so we bring all of that to life through the person-centered practice framework, which is a theory that tries to capture all of this into an organizational framework to help us think through how do we create these kind of flourishing, healthful cultures where I work and where I live. The framework is used around the world in an array of activity, in strategy and policy, in curricula, and a lot of other work and research. It's been translated into a number of languages, but we've also developed a number of instruments for evaluating the person-centeredness of particular settings in health and social care. The framework works from the outside in, so it works from the macro context through to the individual outcome. And that's because we know that we all exist within this large global macro health system that influences the way we practice and shapes the way we practice. But of course, we influence the other way out as well through our experience and what we share. And what I want to do now is to just deconstruct the framework a little bit and say something about each of the domains and relate them to some of the experience of COVID. And I'm sure you have lots of experiences of your own to draw on as well. The macro context, as I said, is the large health and social care policy, be it at a global level or at a national level. And none of these components of this domain, the constructs of this domain, are probably unusual to you, the ones you will recognise very readily, I would imagine. In COVID, we have seen a lot of challenges around some of this. So we have seen some challenges to the regulators, particularly around care homes and what happened to nursing home patients and the way patients from hospitals were moved into care homes and what happened to those residents as a consequence because of a lack of policy in place, a lack of PPE and the infection control measures not being ready, in a sense, for receiving those residents into care. And so that's an example, I think, of where we saw some of this macro context really influencing, not in a good way, the experience of older people, families, care workers and nurses in nursing homes. The prerequisites are those qualities and attributes we need as nurses to be able to work in a person-centered way. So this is about how we help to develop the qualities needed to be person-centered in our practice. We have identified 5 constructs within this domain, and the one that we named first is that of knowing self, which is who am I as a nurse? What values do I feel strongly about? What do I bring into the situation, into the care situation that I'm connected with? The other one I want to highlight here is that of commitment to the job, because commitment to the job is not about working harder, long hours, extra shifts. Commitment to the job is a phenomenological idea. It's the idea of being present, of when I'm at work, I am present, I am with my colleagues, I am bringing all of myself into that situation. I'm not just thinking about getting through the tasks, getting them done as quickly as possible and getting out of here. I'm actually genuinely engaged and connected with my colleagues and with the patients or residents that I'm providing care to. And of course, again, during COVID, we saw a lot of challenges to the state of these prerequisites among the nursing population, really, some of which was about the knowledge that was needed by many nurses in the context that they were working, or if they were moved to a different setting, which many were, whether they had the knowledge, skill and expertise to provide that care. And we saw some of that too, as nurses being moved into nursing homes, having never worked in a nursing home before, and the impact of that on residents. And I guess the one that really interests me currently is this linked to the idea of interpersonal skills from a person-centered perspective, and the idea of wearing masks and having distant relationships. How do we kind of retain an interpersonal connection when wearing a mask or having to keep a distance from the person who we're connecting with? A colleague of mine who's a creative artist has just won a grant to do some work in nursing homes focusing on hands and gloves, because so many older people now are experiencing touch through a glove. And what does that mean for that person and for me as a nurse who is having to work in that way? The care environment we know to be really the mediator of all of this. So the macro context can give us direction about what we need to be doing. We can help people to develop the knowledge, skill and expertise to be person-centred, but I could have the best qualities as a person-centred nurse in the world, but if I work in a care setting that actually doesn't enable me to put them into practice, then I can never truly be person-centred. And in this domain, we've identified a number of constructs that, again, are probably very familiar to you, but which we would argue have got to be worked at all of the time to create a culture that enables person-centred values to flourish, so that people can experience person-centred care, person-centred relationships, person-centred ways of being. And again, during COVID, there have been some challenges to some of these contextual issues. And again, I'm sure all of these are very familiar to you. But just the rapid change that people had to go through, some research I've been involved in with colleagues in Denmark has really shown the impact on clinical leaders in trying to hold some of these contextual changes that happened, and the relationship between the organisation and the clinical settings themselves. And how that played out, and whose outcomes were being worked with. All of that, I think, created very challenging care environments to retain some sense of person-centeredness. The person-centered processes, or as they are often referred to as the petals of the flower, reflect the kind of 5 core processes that we engage in, so practices that we engage in when we're being person-centered. And we are seeing this largely as being about the nurse connecting with the patient, the service user. How do we connect with them? So it's about working with the person's beliefs and values again, being authentic as a nurse, not pretending to be something I'm not, but being real. Being sympathetically present is different to empathy. It essentially, again, is a phenomenological idea, and it's the idea of being present with the person. I can never be you because we are all individuals, but I can show you that I am committed to supporting you, to helping you through your suffering, to staying with you on your journey. We do that through shared decision making and also working holistically, of course. And again, there have been lots of beautiful practices emerging during COVID, some of them in care homes, for example, rainbow boxes, which are boxes that families made, communities made to provide additional comforts for people to help them feel better about the situation they were in. Different ways of being present. We've seen a lot of use of multimedia to engage and help people feel present, and an emergence of virtual reality. And we have some projects happening here in Edinburgh with the use of virtual reality with people with dementia, but also at end-of-life care, which has been a really profound thing that came out of this experience. And the outcome, as I said, is a healthful culture, that all of us are able to live a positive life, the best that I can. And we've identified a number and have developed a number of measurement tools and processes for evaluating that outcome. And I'm very happy to talk to you further about that during the Q&A if those measurements and tools are of interest to you in moving forward. And so, to move to the final part of my presentation, the organizational developer Otto Scharmer talks about coronavirus and COVID-19 being a time when we can pause, reset and step up. And I genuinely believe that COVID-19 provides us with that opportunity to really relook at what it is we're about and what we're doing, and to think about how do we go forward. I think, as Sharma says, we do have a choice here. We can freeze and just wait for it all to return back to some kind of normal, or we can actually look at moving forward, look at what choices do we have, how do we create a world that actually may be more compassionate, more person-centered, that helps us all to flourish. And I want to think about that for a minute in relation to person-centered work. Some students that I've been working with have created this image when we talked about person-centeredness and what it means for them as they grow as students. And one of them, or this group, actually indicated that really what it meant for them was that they could leave an imprint. And this is a really, I think, important statement for us as nurses. As a nurse, the thing I want to do most is to leave an imprint on the people who I connect with. That's something that makes them feel that they've had a good experience. And for me, I've been involved in some work that's about places to flourish. How do we create, in a residential care context, places where older people can continue to flourish within their world? And I think I'm focusing on this here because of what has happened in care homes, in particularly around COVID, and how do we move out of that narrative into one that's about flourishing, to actually ensure we reset the clock in relation to nursing homes, to ensure that we are focusing on people flourishing in those settings. And I believe really strongly that we've got to really move away from it all being rule-bound, regulatory-bound, protocol-bound, to actually look at the patterns that exist within our care settings. Patterns really interest me because they're often unwritten, they're not written down, they exist through the energy that we share, they exist in the unspoken practice that we all engage in, but they generally shape how we all experience our day-to-day world of practice. In our work on flourishing in nursing homes, we identified 7 typical patterns that older people and residents engage with. And I think we can't underestimate the power of these patterns really helping to shape somebody's life and ensuring that they are having the best experience through day-to-day living within that nursing home. And these 7 patterns are probably, again, very familiar to you, and ones that we need to pay attention to. The one I'm personally very interested in is the idea of personal and secret spaces and places. Places where, if I'm a resident in a nursing home, I can go to and hide and just be without being observed, without surveillance, all of those things. And we can look at these patterns in a positive way, and this again comes from some evaluation we did around implementing work in nursing homes to develop these patterns of care. So how do we affirm the values and enrich an older person's life through our ethos of care, through the values we hold within that care setting? Creating different connections through family and community and carers and friends, all working together to create a culture that's flourishing, being different ways of participation, of using story and narrative, and also really challenging the rituals. Rituals are important, but also are all our rituals needed, or can we develop new rituals that can help people to flourish? Again, drawing on issues around place, how do we ensure that the people living in our nursing homes feel a sense of connection, feel that sense of connection from their room through to the big city, if that's where they come from, or the big farm, if that's where they come from, that we hold on to that sense of place, that we give them back those memories, those spaces, to be able to feel whole in that one room, if that is their world at this point in time. And so much of this requires us to shift our power base. Models of care that are about households, that are about breaking down hierarchy, getting rid of uniforms, getting rid of all of these trappings, really start to help create a greater sense of community and a greater sense of power sharing between all of us in these settings. And that requires us in our teams, going back to the care environment, to really pay attention to how we connect with each other in a person-centered way. How do we engage with each other in person-centered decision-making that's respectful, that's caring rather than power-driven, that our relationships are healthful and not energy-draining and destructive, but actually they nurture us. How we deal with conflict. Conflict is about questioning, it's about challenging, it's about connecting with each other, and continuously learning and having leaders who facilitate these kind of cultures is really critical to moving forward. And I want to end with a very busy slide, really, and I'm not going to spend any time on it other than to say that if we think about all of these things, if we think about these patterns, these ways of engaging and connecting, then we can see person-centeredness as a whole systems approach to our practice, to how gerontological services are constructed, and to how we engage as gerontological nurses. And in our 2017 publication, I've written extensively about how we take these 15 properties of a person-centered organization and implement them, because I believe very strongly that unless we see person-centeredness as a whole system, then patients, service users, residents, older people and staff will never really experience person-centered practice in its fullest form. They will only experience what my colleague Tanya McCants and I have described as person-centered moments, and we can do better than that. And so, to end, I think we have a great opportunity now to really think about how we want to move forward, to really think about the reality we want to create as we move forward. And actually, it may not be just tweaking what we had before, but to actually really build a new model of older people nursing that embraces the creativity and the energy that we bring to it as older people nurses, and that help us to enable everybody to flourish in their lives. Thank you.
Hi, Brendan. Good to see you. Bridget here. Now, one of us is muted. I'm not sure which one.
Oh, it's me.
Here we are. Oh, we'll let you off. It's very early in the morning.
I'm no longer mute.
Hi, so Brendan and I met you about 20 odd years ago when we were both over in the UK.
I know.
Natalie Seymour, who's the incoming chair of our College of Gerontology Nursing. So she's just going to help me with the Q&A part of this.
Great.
Thank you so much for your patience and your resilience in sticking with us over this period of time.
It's a pleasure.
Yeah, everything else. So I've got a couple of questions to start with, if that's okay.
For sure.
Flourishing and languishing. How would you describe somebody as looking as though they're flourishing? Is there something that you can see in them that makes you feel that they're doing really well rather than doing the languishing part?
It's a really great question, actually. And I suppose I'd want to distinguish flourishing of an older person in a care setting and flourishing of a care provider, be that a nurse or a care worker. I think I'll start with the latter first, which is the nurse or care worker in terms of their flourishing. I think that's possibly easier to spot and to observe because it's, we have lots of studies of what an effective team is, what effective practice relationships are like, what it means for somebody to be, in a sense, happy in their work. And I think we can see that in all kinds of ways among care teams. And I think the thing that stands out most for me in relation to somebody or even a team that's flourishing is that they are energized, that they are passionate about what they're doing. They're not drained by it, and we all know what that feels like. I can almost feel my body right now reacting to it as I say it, in terms of what it's like when I'm in that situation, because it feels lighter. You can see people almost kind of skipping around the care environment. They're enthusiastic. They're not paying attention to the watch and time checking and those kind of things. So it's a whole set of behaviors actually that go with a member of staff or a team actually being in that flourishing space. And I think it's dead easy to see and to observe in our work. I think for an older person in a care setting, it is a bit more difficult to see because it depends on how well we know that person. And so therefore it very much is about the kind of assessment that we do with that person and what it is we pay attention to. So if we do an assessment that is more humanistic, is more focused on getting to know the person before it is about bodily functions and diagnosis and those kind of things, then I think we start to understand the kind of ebb and flow of that person's body and their energy and what they react to and what they don't. And in that context, of course, what it depends on then is a nursing structure, a care structure that enables staff to sustain those relationships. So if I have continuity of care, then of course I'm going to spot those nuances. I'm going to be able to see, you know, that slight difference in response. We had a large research grant actually from the National Institute of Health Research here, working in care homes, which is just being reported on actually, where it was based on trying to prevent older people in care homes from being unnecessarily admitted to acute hospital. And what we wanted to build on was how care workers, as in non-registered staff, and families spotted changes in their resident, in their family member, and how did they get reported. Now, the project was really difficult actually, but and it was a clinical trial, which made it even worse. But what we were trying to do was to, instead of, you know, we all do it, you know, family members will come into a care home and say, you know, my mum looks slightly different today. I'm not quite sure what that's about. Is she okay? And often a care worker will just go, yeah, she's fine. She's just a bit tired, or she didn't sleep too well. But actually that's often a trigger that something is changing, you know, that something is starting to change and it doesn't get reported or assessed. And the opposite is true then of somebody who's, you know, an older person who is flourishing, when we can see that, you know, they're more willing to touch, they don't recoil, they're not engaging in so-called challenging behaviors. All of those things are not present, then we know that they're flourishing. And so, but that is so fundamentally about knowing the person to be able to spot those and to work with them.
Yeah, yeah. Absolutely. I was just reflecting on my own practice at the time and hoping that I was able to spot those flourishing and languishing ones.
Yeah.
You also, during your presentation, talked about the measurement tools and the outcome tools. I just wondered if you were able to just give us a flavour of what sort of outcomes they're measuring that may be of interest to some of our colleagues in New Zealand.
Yeah. So we have, because you may have picked up from the presentation, particularly around the framework, the way we have positioned the framework as a theory, that we are less interested, but I'll come back to this point again in a second. We're less interested in measuring or evaluating particular interventions about whether they're person-centered or not. But what we are interested in is how do we evaluate a person-centered culture, a whole system, essentially. Because of that belief that I said, which is that if we only focus on the care practices, then I don't believe, and our evidence would suggest, that it's not possible to sustain person-centered practice. We can't just expect staff to do individual practices in a person-centered way if they're not in a culture that nurtures and sustains that for them as persons as well. So what we have tried to do is to develop instruments that capture each of the 5 domains of the framework, and that focus in then on the individual constructs within each of the domains. And so what they're picking up is essentially how those constructs play out in everyday practice. And we are currently doing some work. We've got a paper in press at the moment where we're trying to test the relationship between the constructs in the different domains. You know, so what might be the most significant construct, for example, in creating a person-centered context. And we're starting to see some interesting results from that. We've reanalyzed, particularly work we've been doing in Ireland. We've got a data set of about 5,000 nursing responses that we've been working with to try and see, can we see which constructs kind of come to the surface more than others in relation to affecting a person-centered culture. So we've now got a number of versions. We've got what's called the Person-Centered Practice Inventory Staff, the PCPI-S, which is an instrument for multidisciplinary staff in a setting to use to evaluate those domains and constructs. We've also got, we're still at the early stage of testing, but it's showing quite positively a service user version of it, which is a much shorter version. And it just focuses really on the care processes and the outcomes. And it's really for residents, patients, families to complete, to get their perspective on what that culture is like. And again, we've tested that now in Australia, in Ireland, in the UK, and in Austria, and it's currently being tested in Sweden and in the Netherlands. And it seems to be consistent. So we're just at the end of the face validity testing of that. And then we have quite an interesting body of work going on around students' perspectives on person-centeredness, because they come in and out of environments all the time. So we have the PCPI SU, which is the, ST, which is the student version of it. And we have a couple of PhDs going on where people are working with that in practice and seeing how nurses in particular make sense of it. And then alongside that, we have two other measurement tools, processes. One is an observation instrument that we developed some years ago, but we have redone it, and it was published last year again, where we have aligned the observation constructs much more tightly with the theoretical domains, so that an organization or team can start to observe, just as we've been talking about, Bridget, you know, is this a flourishing intervention, or what's going on here? And then the last part is the work that my colleague Tanya McCants has been doing in Northern Ireland, and we've been collaborating with her on around some key performance indicators. So we have identified 5 key performance indicators of a person-centered team, essentially. So what we argue is essentially, in any evaluation of a person-centered culture, we need to bring all of those perspectives together. It's not enough to just look at one thing. We have to bring them all together over a period of time. You can pick out certain parts of those, of course. And those instruments are now, I mean, the PCPIS has been translated into about 13 languages at this point, and has been used quite widely around the world. And we're currently working with the team in the Swedish Centre for Person-Centred Care, where they have focused much more strongly on person-centred interventions, particularly in cardiac practice and in orthopedics, in the large hospital in Gothenburg. And what we're doing now is actually collaborating with them, because what they've done about 15 clinical trials of person-centred interventions, nursing interventions mainly, actually, in acute care. But what they've discovered, funnily enough, is that none of these interventions are sustainable because the culture hasn't changed. So they're now looking at, we're joined up with them to, in a sense, bring our tools into that space to see, can we see any correlation between shifts in the way the culture changes and how these practices might be sustained over time. But they're all pretty much freely available. The ones that may not be fully available yet, I'm more than happy to share, because we're keen for people to use and play with and do their stuff with, really.
Yeah, that would be great. Thank you. I think we've got
Yeah, so we've received a question in from one of the attendees. So the question for you is, where does the being authentic petal sit with assisting clients with practices that are the polar opposite to the nurse's values? The example they've provided is a non-religious nurse who is personally against the concept of prayer, may still feel that it is more therapeutic to pray with a client or allow them to pray. Is it more important to allow the client to express their religious beliefs than to be authentic?
Great question again. So I guess I would, one of the discussions I would want to have with that person is how we're constructing authenticity in that context. And again, it depends on which philosophical perspective you come at or come from in relation to how we view being authentic. So being authentic in one hand, which is a kind of an Aristotelian perspective as well, although not exclusively. It depends on if you selectively read Aristotle or if you kind of take a broader approach to it. That authenticity is about living by my values and not shifting from those. But of course, that has a kind of a belief that our values are static, our values are somehow fixed and immutable, and that we always work with them. But of course, we know that that's absolutely not the case. If you take a more phenomenological approach to values, and in fact, Aristotle himself was very clear that our values grow as we grow. And so for me, authenticity is not so much this fixed, immutable values that I hang on to for dear life, but it is much more of that reflexive, the more feminist idea actually around values, about how we engage in a reflexivity that enables us to understand my own ontological stance and where I stand, but then being able to almost create this universe around me that is a domain of practice that allows me to in a sense, move those. So I could buy into this example very easily, because I'm not religious. I don't believe in prayer as a powerful force. But of course, I do believe in things like poetry and prose and the power of narrative. And if I just see prayer as another form of narrative, then I have no problem with engaging in a prayer with that person. I don't have to own it. I don't have to buy into the meaning, but I can buy into the energy of it and the connection that it creates between me and that person. They get what they get from it, which is that religious uplift, and that's absolutely right. And I get what I have, which is a connection. So I think and I think this is so important as gerontological nurses, that we don't create these fixed, immutable stances and somehow believe that that's authentic, because actually it isn't. It kind of starts to create difficulties. So yeah, that's how I would work with that, and I think it's a great example of the kind of skill and expertise that's required as gerontological nurses to do that kind of work.
Thank you.
Fabulous.
Great answer. And I think that what you referred to before is around gerontological nursing is always going to have ebbs and flows, and it's about adjusting yourself to the situation that you're presented with. So,
which we know is the absolute skill of an expert gerontological nurse, of having that fleetness of foot to be able to just respond in that space. And of course, when working with people with dementia, we know we can't be fixed. We have to be those time travelers that I mentioned in my presentation. You know, we have to travel through time all the time with a person with dementia if we are going to be person-centered with them.
Have we got time for one more question?
yep, we do.
Hopefully.
Yep, we do.
You mentioned in your presentation the patterns that you see over time, and that these were the things that, you know, piqued your interest at the moment. I was just wondering whether there was any patterns that you could share with us that would resonate more than likely with us over here.
Yeah, it depends where you want to start. Really.
Oh my
We've been
goodness.
doing some. It's a really interesting area. We've been involved leading a program of work in the Republic of Ireland, actually, for the last 3 years. Working, so it was commissioned by the Health Service for us to work over a 3-year period with really every setting that wanted to, which is as narrow as I can narrow it, really, not just older people. And the idea of it is, because they've done a lot of work around developing person-centered practices and cultures, and particularly in older people's services and in services for people with intellectual disabilities. But actually, again, that same issue of, you know, not a lot of it sticks. Some of it does, but not to create a kind of a proper system-wide change. And what the Health Service commissioned with us was a program of work over 3 years to develop person-centered facilitators who would be embedded in each of these clinical services, so that the work got sustained. And that is what's happened. We've developed about 500 or 600 facilitators now, who are all dotted around the systems and doing some fascinating work. But the thing that we focused on with them was around the patterns, and how do we kind of get inside some of these patterns? Because like all our health, or all our long-term care systems in particular, and all of they're so dominated by regulation and rules, and, you know, lots of negativity as in what you shouldn't do rather than what's possible. And so we developed very much an action research type project. We developed a way of mapping patterns, which really meant we got large sheets of wallpaper on the floor, and kind of created a whole map on the floor. And we just spent our days and our bare feet kind of walking through these large maps of practice, and creating lots of connections between staff patterns and resident patterns. So we picked one that might interest you, that really interested me, because I started my life as a mental health nurse back in the 80s when it was not that healthy. And one of the ones that particularly interested me was the use of cigarettes in residential care as a bargaining tool. and how now it seems so innocuous, and actually I thought that practice had died a long time ago, but of course in some of our large institutions it hasn't actually, or in smaller institutions even, and how things like cigarettes, sweets, food are used as bargaining tools between staff and residents. You know, it's kind of an infantilization of residents, that if you're a good boy, you'll get a cigarette, or if you don't behave in that challenging behavior, you get a drink, those kind of things. And actually we spent probably the best part of a day unpicking this particular pattern because it's so illustrative of, you know, institutionalized culture, of staff who are not flourishing, who are in a mode of being. And we really stripped it all right back, and we just had this huge kind of I don't know, like a spaghetti picture of all these connections, that when you started to unpick this quite innocuous practice, it really was a kind of a holder of the whole system, of all the cultural elements that were going on around, you know, staff support, you know, how breaks were managed, how shift patterns were managed, the way residents were viewed. It was absolutely phenomenal, really, in relation to unpicking the culture. And that has formed really the basis of a lot of the development work that happened since across those intellectual disability units, and really trying to shift that culture quite significantly in some respects. And you know, I could talk about that one for hours, because it is just so interesting in relation to, you know, routines and rituals and historical practices, beliefs and values, how we view persons, a whole array of things. We did similar things in care homes with older people, particularly around supporting people with dementia to take risks, and especially around the issue of locked doors, and how do we handle locked doors, for example, and opening up those spaces so that they become much more open, really. So those kind of things have been really powerful, and I think probably resonate with all of us if we've been in practice for any length of time, really. But the thing I want to say about those is those things are rarely written in protocols or standards, or they're kind of those hidden practices. And that's the thing about patterns, is that they sit behind all of the formalized practice. The practice that's overt in our protocols and standards is the kind of idealized practice, but of course behind that are all of these patterns of engagement and behavior that are often never talked about or even expressed.
And I'm guessing some of that was brought up through the observations of care kind of techniques that, you know, I learned from you many years ago. I think that we've run out of time, unfortunately.
We do have a couple of extra questions, Brendan, so we will get those sent through to you to answer, and then we can send those out to the attendees. Out of time. But I know we could probably sit here and listen to you all night.
Yeah, absolutely. We'll have to get you back.
I'd love to.
Yeah, thank you so much. That has been great. I haven't heard much about person-centred care or personhood recently in New Zealand. So for me, that's been absolutely fabulous. And thank you.
Great. Thank you so much for asking me. And I'm sorry I can't be there. But one day it'll all return.
Okay. Thank you very much, Brendan. Much.
Thank you very much. Good to see you.
Bye.
Bye.
Right. Wow. Now, we're now going into the College of Nursing Biennial General Meeting. So first of all, housekeeping. So from this point forward, we're going to be using the chat and the raise hand buttons, please. And we won't be monitoring the questions and answers during this session. Again, just check that your chat function is set to all panelists and attendees. And all registered members of the College of Gerontology Nursing, please can you now use the chat function and put in your first and last name into this so that we can record who's actually here in terms of meeting our quorum and completing our business as such. We may make a call for nominations of people to join the committee. When we get to that stage, we would need your first and last name and the name of the person that you were nominating. We would then need the person being nominated to accept the nomination. We have two separate places available on the committee going forward. However, if we don't get nominations tonight, then we will put out a call for nominations through the usual email channels and newsletter processes. Where are we? Next piece of paper, sorry people. So I have to call the meeting to order and declare the NZNO College of Gerontology Nursing 2020 BGM open. I'd like to welcome all college committee members and guests to the BGM. Our rules dictate that we require 5% of our membership present to meet the quorum, which means that we need 30 people present, hopefully. 30 college members to meet our quorum. So I'm hoping that you are very busily putting in the chat who you are and that you're here. I'm not 100% sure we actually have the required quorum, but we will continue. Okay, so I'd like to just introduce the national committee members and like to acknowledge the other committee, the college members who are also present. So there's myself, Bridget, the outgoing chair. I've got Natalie with me, who's the vice chair and the incoming chairperson. We have Kim Brock, who's our treasurer, present. Kim Brock, sorry. Gayleen Watkins, our secretary. Aileen Smith, our outgoing committee member. Anna Carey, committee member staying on for the next term. Morag McKenzie, committee member staying on for another term. Napat Sirihongthong, committee member staying on for a new term. And we have Aloha Sisson, who has been a co-opted committee member, but has now been
we need to
nominate.
yeah.
Well, she's been nominated and put her nomination through, and that will be accepted. And Mark Bixby, who's our professional nursing advisor. All AGM papers are available on the College of Gerontology Nursing website. Do we have any apologies from anybody? I'm not aware of any. If there are any apologies from people, could you again pop that into the chat box? And we will now move on through the agenda. Do any members have any other matters or changes to the order of business as it currently stands that you wish to make known? I'll give you a moment just to consider. Oh, and remember to raise your hand, please. Okay, so the minutes of the previous meeting have been distributed to everybody. I'm not planning on reading them out today. Is there anybody that feels that there should be any changes made? No. in which case I'd like to call for a vote to accept the minutes if no changes are required. So I call that the minutes of the College of Gerontology Nursing 2018 BGM are accepted as the official record of the meeting. Can I have a mover, please? Kim Brooks.
Thank you,
And seconder, Maureen Mackenzie.
Thanks, Maureen.
So I will therefore sign the minutes before leaving the building. Matters arising from the minutes, I don't believe there are any. Any correspondence? None has been tabled. The financial report. Kim, would you like to?
Hi everybody. So financially, I'd just like to give you the last summary from our financial year ending March 31st, 2020. Normally this would have been done in May when we first were going to have our AGM then, but however. So total income for the 2019-20 financial year was 15,684. Expenses totaled 16,268, resulting in a net deficit of $600 after tax of $16. No conference was held in 1920. We maintain income item for the year was 15,229 from the NZNO for core funding. This funding this funded committee meeting expenses, accommodation, travel expenses, meeting expenses totaling 13,025. The other main items of expenditure were marketing of 1,242 and regional division expenses of $906. Just in terms of that last financial year, the college, including divisions, ended the financial year 31st of March 2020 with a cash in the bank, including term deposits totaling 79,675 compared to 86,016 in March, 31st of March 19. The main reason for the drop in cash of $6,000 relates to a payment of $10,000 for seed funding for the 2020 conference paid in August 2019. During the year, decisions were made to close 3 of the regional divisions of Auckland, Otago and Te Tokoro and transfer the remaining funds to the National Committee. Auckland and Otago divisions transfers funds of $38,865 and $3,146 respectively. The final balance for Te Tokoro branch was $1,517 and was transferred in May 2020. The Otago division requested that funds transferred be utilised to fund the welcome function at the 2020 National Gerontology Conference. And as we all know that hasn't happened, but those funds have been transferred to the National Committee. So I'd like to put forward a motion that the annual accounts be adopted. And I have a seconder, please. No, Pat, thank you. So it is open at the moment for discussion. So I'd like to ask the chair to call for a vote if there is no discussions that the annual accounts be adopted.
Is there any questions or queries around the accounts?
Don't think so.
No questions.
Okay, so I would like to state that the motion is carried. And we've adopted them.
Good.
Just moving on to the chair's report. Again, I wasn't planning on reading this out. I would just like to note that I have written this 3 times. And I'm not sure if anybody has been brave enough to read all 3 versions, but the latest version is on the website currently. I would like to put a motion that the chairperson's report be adopted.
I'll move it.
Thank you, Marg. Marg Bixby has seconded that. Is there anybody that would like to make any comments or discussion around that? No? Okay, in which case we will call for a vote that the chairperson's report is adopted. Is there anybody against that motion?
Nothing's come through.
No, in which case the motion is carried. So we're now on to the professional nurse advisor report. No, but do you want to say anything briefly? I'm going to run away because I'm going to leave that to Matthew.
Good evening, and I'm Marg Bixby, as Bridget introduced me before. I do have a report, and it's also will be available or has been distributed online. And again, like Bridget, I won't read it. But unlike Bridget, I only wrote it once because I procrastinated for longer. So didn't. But I just wanted to reflect on the work of the college and pay tribute to the outgoing committee members in particular, and also just reflect on the significant contribution to the well-being of older people through the challenging year that we've had, made by people working with older people in aged care and in the community. So you have my respect and admiration, and thanks again. So do I need to, or do you need to?
Well, Madam Chair should be doing this, but we call for a vote that the P&A's report has been received. Has anybody got any questions, queries, or abstaining? No. Thank you, Bridget, for seconding. Has anybody got any other questions or queries? Okay, so in that case, it has been carried. So if there are any particular members that are still online that haven't put their name into the chat box, could you please do so? And it can only be the registered members only, please. Thank you.
We had one policy remit that was out for consultation and for voting on. As ever, the College of Gerontology Nursing voted in their huge numbers. The remit is that student nurses are able to become eligible members of the College of Gerontology Nursing at the we adopt the rules wording to read: a student who is undertaking a programme of education accredited by the Nursing Council of New Zealand with a view to registration, who has current NZNO membership. I think that that's fairly self-explanatory. And I would like to propose that. Can we have a seconder? Thank you, Anna Carey. Is there any discussion that we need around this? Is everybody fairly happy with that? Is there anybody online who's... No. Okay, so the vote was a positive vote online, so we will say that that's been carried and that will now be part of our rules. Now it's your turn.
So we'd like to announce that we do have a new committee member Aloha Sisson. She has been co-opted to our college this year, and we would like to make her a more permanent fixture. I'm quite happy to actually move that we do have Aloha stay on our committee. Yep. Oh, everybody, so it's unanimous.
Thank you.
So we are also really sad and really sorry to be farewelling 2 of our valued committee members this year. One being Bridget, who is our current chair. Bridget has been instrumental in getting us to college status, and also Aileen Smith, who has been a committee member and has tirelessly looked after all of the new members. Both are going to be sorely missed, and we value everything that you've both had to offer over the years. And I know that it's certainly made my life very easy having you next to me. Your contributions to the college have been absolutely invaluable, so thank you very much to both. And sincerest thanks to your hard work and your dedication during all your terms, which has been a few. And so, yeah, now we would like to welcome our newest committee member, Aloha. Would you like to come and say hello? So this is Aloha.
Hi, everybody. Again, I want to thank you all for welcoming me as a newest committee member, and I look forward to working with you.
Fantastic. Is there any other business that needs to be brought forward? Yeah. So as we do have 2 current committee members who are farewelling us, we will be putting some nominations out, and we would be doing that online. So if you do have any of your colleagues that you'd like to nominate, please do put their names forward. We will gratefully receive them. Otherwise, I think that is pretty much it. So we would like to thank you for all your attendance. We would like to recognise that it is time out of your day and your evening, especially after it's been a long day already for you all. The next BGM will be held in 2022. We've yet to confirm the date, the time and the venue, and hopefully there will be a conference attached, but I guess we'll just need to wait and see on where the state of the land will be at that time. Again, I would like to say thank you, this time to Annika and Shireen. We really do value everything that you are putting together for us. It's going to be really interesting to see what comes out of it. So just to close, thank you again for joining us tonight. Yep, so I'm thinking though. So yeah, where am I up to? And I'm going to hand over to Morag, who is going to do the rest of it.
Lovely. Thank you, team. Me again. What we'd like to do now is to have another presentation for you, and we're moving on to the Design Factory. And the Design Factory is an innovative organisation that I believe there's about 27 hubs around the world, and we are absolutely delighted to be able to have one of our hubs at Wintec. And we have 2 students, Annika and Shireen, that are going to present to you their findings so far. So they are looking at how might we create environments that enable an aged persons to thrive. And I think this fits in beautifully with Brendan's presentation. They'll now be joining us after their pre-recorded presentation for Q&A. And you'll all be pros at this by now, I'm sure. Just remember to use the Q&A function, and remember If you see any questions that you'd like, please upvote, and we can certainly focus on those ones. So Annika and Shireen, take it away. Here's your time to shine with what you're doing so far.
Ahi ahi pai, tēnā koutou katoa. By 2050, our population is expected to comprise 25% over the age of 65 years. Our rapidly changing and evolving demographic requires a responsive, innovative, and person-centered approach in order for people to thrive. An age-old problem, you might say. We are using design thinking as a new approach toward discovering solutions. My name is Annika Driesen de Vries, and I'm a social worker. And my colleague student is Shireen Hanif. Shireen is a registered nurse. For this project, we call ourselves Grey Matters. You, the College of Gerontology Nursing, are our industry partners, and we are supported by our tutors from Wintec, Leanne Ryan and Aidan Bigham. We are excited to present to you a snapshot of our Master's Health and Social Practice project from Semester 1 and an update of what we are working on in Semester 2. At the end, we will be available for a short Q&A session if there are any questions. I would like to hand over to Shireen, who will take you through the methodology we used.
Thank you, Annika, and hello, everyone. For our research, we are using a way of working called design thinking. Design thinking involves solving a wicked problem. Our wicked problem in Semester 1 was how might we create environments which enable aged persons to thrive. There are multiple versions of design thinking process. We use a 5-stage process. Stage 1 is empathize, which included secondary research and ethnographic interviews with health professionals, family carers, and people aged over 65 within Hamilton and the Tauranga region. Stage 2 is define. Primary and secondary research were clustered into key findings and insights were generated, followed by stage 3, ideate. Creative ideas were put forward after analysis of data from the empathize and define stage. These ideas range from the wacky and wonderful to the so simple it might be silly. Stage 5 is prototyping. This is the mock-up solution phase, where ideas were created to gather feedback for the final stage. Stage 5 is testing. Does this work? It is important to note here that the process is cyclical and we can move between steps as we need to when new information comes to light. Today, our presentation will focus on the empathize and define stage, especially the areas seek to understand, insights, and challenges, how might we questions. Empathize. Insights from our industry partners. During this phase of our project, we conducted interviews, either face-to-face or via Zoom, to understand the challenges of providing care for aged persons from a workforce perspective. In Semester 1, we were faced with contact limitations due to COVID-19. This meant we were unable to interview people who lived in aged residential care. However, our interviews still showed that working in the aged care sector is perceived as a stepping stone rather than a career choice. There is an aging workforce, and aged care is not viewed as an attractive area of nursing. Working in an aged care facility carries high autonomy and high responsibility. You must manage it yourself because there is not a readily available multidisciplinary team.
Empathize, insights from an aged person's perspective. As mentioned, a limitation to our project in Semester 1 was the impact of COVID-19 on our ability to interview people living in residential care facilities due to the lockdown measures in place. However, interviews conducted with family carers and people aged over 65 provided interesting insights. 1, loneliness and isolation are a constraint for aged persons to thrive. Support networks often involve family, friends, and neighbours, but sometimes very few of these. Support networks often involve geographical distances, leading to isolation. 2, families are a hinder or help for aged persons to thrive. Many older people wish to be closer to their family as they age. Families experience a lack of support as caregivers for their loved ones. They also have high expectations of aged residential care. 3, future care planning enables aged persons to thrive. Most older people that were interviewed have knowledge of estate planning and enduring power of attorney. Those interviewed felt assured if their affairs were in order. There is limited awareness and knowledge of advanced care planning, however. Not one person who was interviewed wanted to enter aged residential care.
4, collaboration enables aged persons to thrive. Health professionals believe that collaborative decisions have better outcomes. They have knowledge of person-centered care. At the same time, they are protective of their professional expertise and can end up working in silos. Number 5, the workforce supporting the aged person needs respect. Many care workers feel undervalued by management and other professional colleagues. Across the board in aged care, workers felt there was not enough staff to get everything done. Workers often performed extra hours and tasks out of the goodness of their heart. Let's now move to the next stage, define. So we have built up insights during the empathize stage. The define stage of design thinking identifies challenges and pain points that will require solutions. From our insights, we identified the following challenges. Number 1 was isolation. There is a need for connection and support from friends and family and a need for future care planning. Many families in our globalized world are living apart from each other, with traditional care frameworks under pressure or abandoned. Also important to note is that isolation is not about the quantity of contacts, but the quality. Number 2, there are issues with the workforce and attributes needed to work in the industry. For example, the discrepancy between practice-based knowledge and theory, as well as working in isolation. There is a need for a multidisciplinary approach. A common theme was that patient-to-care ratios being so high, it was difficult to provide person-centered care. Number 3, self-positioning about age from the aged person and wanting to age in place saw many interviewees stating age is just a number, and all saying they wish to remain in their own homes and communities. Number 4, communication, advocacy, and valuing the voice of the aged person needs to be improved. For example, one of our interviewees stated no one had asked her opinion prior to being locked in during COVID-19. Number 5, there are issues with current systems and facilities that are in place for aged persons, issues with access to healthcare, and issues with the use of technology. One of our findings was that systems are antiquated and there has been no investment in technology over the last years because of the cost-cutting measures. Number 6, there is a fear that comes with getting older and a stigma or perception surrounding aged care. So what is the process now to create solutions for these challenges, Annika?
To create a suitable brief for solution design, the challenges from the previous slide need to be condensed in new how might we questions, because asking how might we drives action and solution. The following questions were formulated. 1, how might we address discrepancies in accessing healthcare, ensuring there is adequate resourcing and funding supported by technology to meet the needs of the older person? 2, how might we foster a multidisciplinary and collaborative approach towards aged care, recognising that people are living longer with increasing comorbidities? 3, how might we support older people to stay in their own home environment for the duration of their life? As you can see, these are great questions for driving solutions, as the solutions can be tested and retested against the question, did we solve the how might we question? So this is the basis for the next stage of design thinking, the ideate phase. The prototypes we designed to address the new how might we questions were created in the ideate phase of design thinking. Ideate, as previously mentioned, is the mock-up solution phase of prototyping, where ideas are created to gather feedback for the final stage of testing. We created 2 prototypes. One, a My Wellbeing book, designed to be a resource for the client to maintain all information relevant to them and likely to need to be repeated frequently by older people engaging with health professionals and support services. The Wellbeing book serves both as an information bank and map of the journey to date. It is not designed for clinical notes. The Wellness Expo was designed to give access to information older people might need to enhance their well-being by having knowledge of what is available to them, how to access it, and costs associated with using a service. Both prototypes were well received with good feedback and suggestions for improvement. In this phase, we experienced firsthand how valuable the design thinking process had been to getting to these prototypes, but also how valuable user testing is. So Shireen, what are we doing this semester?
Having learned the methodology of design thinking, we are now embracing the second question given to us by you, our industry partners. How might we provide expert care to an aging and changing population in Aotearoa, New Zealand? So far, we have undertaken secondary research and are currently interviewing across 7 different cohort groups, namely staff who are working in aged residential care, staff that have left jobs in aged residential care, older people who are considering aged residential care or alternative living arrangements, older people who are living within aged residential care, older people who are choosing to live in home or not living in aged residential care, families of the older person who has chosen to live at home, or families of the older person who is living in aged residential care. This semester, we are delighted to be able to enter aged residential care facilities, taking into account safety precautions with COVID-19 regulations. Once all of the interviewing is complete, we will move on to customer journey mapping and the creation of personas again using the design thinking methodology. Annika and I are grateful for the support of the college and look forward to communicating with you further. The question and answer session will now follow.
Hi, everyone.
Hello. Hello, Shireen. And Shireen and Annika, thank you so much for that wonderful presentation. And we're delighted that you're on your journey and we're able to support you with that, because I think what you will find will be extremely enlightening and very beneficial for all of us. We've got a couple of questions for you here. And I think just to ask, I mean, how did COVID impact on your research?
It made it really, really hard. We were sort of, I think, acutely aware that we wanted to get a full picture, as full a picture as we could, and yet we were acutely aware that the picture we were creating was influenced by our inability to get into residential care facilities. So we did keep that in mind and had that as a limitation to the study.
Yes, absolutely. I mean, it's been a fraught time all round, really, and we certainly felt for you when you were ready to take off and do your amazing research that it was, difficult for you. Just another couple of questions that have come through here. Just writing them down. Was technology used at any point during COVID? Could you Zoom in, or were your older participants using technology as well? So not just phone calls, certainly no face-to-face at that time, but were there other avenues that you could still connect with your research participants?
We thank you. To interview people, we ended up using Zoom. We certainly used WhatsApp calls, email. Some people emailed through their recorded themselves and sent in their recording to us. We were not able to get people living in aged residential care specifically to use tablets or phones or whatever. It was really hard to organize, in terms of consent, and then in terms of support when it comes to technology. And then with the time frame and the ethics of it all, we just decided it would just be easier not to do it for last semester and hope for the best this semester. So luckily it is working this semester that we're able to get into these facilities.
Oh, that's wonderful. We certainly wish you all the best with the next phase of your research. Another question from the floor, ladies, was, did anyone mention being lonely? I know we talked a little bit about isolation, which was part of that, but did anybody mention being lonely and wherever they were living, be it residential care or in their own homes?
I think we can both probably answer this question, but I'll start, Annika. Last semester, certainly there were themes coming through, but as we interview people this semester, especially going into residential facilities, the ladies certainly that I've spoken with have specifically said that they've been, some have said that they've been lonely because they are unable to see their family members. They don't get a lot of visitors. One of the ladies said that, I'm really lucky that I'm in a mobility scooter and I can go around, but what about those people who have no mobility and are stuck in their rooms? They get no visitors, or there's some kind of impairment in terms of being able to use technology, so they're really isolated and feeling lonely. So that was really interesting to hear, which is kind of why I asked that question earlier in the symposium.
And highlight
Monica?
those connections within the facility as well too amongst residents. Yes.
Mm-hmm.
I think a really interesting point on the lonely question in semester one, a big highlight was that people were less lonely, and that's in the sense of that the community rallied around. So for a lot of people that were living in their home, they made new connections with neighbours, community support groups, people in the street, people in their communities, people they'd never known before. One of a caregiver that I interviewed, she said she returned to one of her clients who has a brain injury, fearing for the worst, and he was thriving. He'd never had so many people being involved with him before this. So I think COVID, in a sense, is a disruptive event that has shown us that actually things can be done differently in a positive way, so that reconnecting with our communities has meant that there was less loneliness for some people. So I thought that was a really positive thing, and that came through with several people.
I think it was also with disruption of how people really ended up using technology and keeping in touch with other people. People were calling and sending photos, and vice versa, with people in facilities sending photos and regular updates, and it kind of really helped those relationships. So it was really I think it's been a push start to let's get this going.
Yeah. And I think you're right. I think there was certainly a heightened sense of supporting each other, not just being kind and washing our hands as we were told, but looking out for each other, which I think has been a positive outcome from that, very much amongst a very difficult worldview that we now have. Just I think one last question. This is looking back at your research. Do you think COVID created a bias in the findings, perhaps?
I'm not sure. I suppose it would be in what way, and what sort of a bias.
I think
I would think my immediate answer to that would be no. I think in terms of that you may get a selected outcome was more based on the people we were able to interview. So there could be a bias in terms of, okay, so in semester one, we didn't get into residential care. But when we were looking at the question around thriving, I think some very common themes came through with that word thrive. Actually, that Brendan McCormack alluded to earlier. You know, it was wonderful to hear him speaking, using the word flourish. And I think when we were using that word thrive, we have the same connotations around that. So I think what people were saying in and out of a facility, and also the people that are attached to each other, so that voice does have a very similar tone. But the biases could be ascertained as us not being able to get into residential care and only connecting with home caregivers or professionals relating to people in their own homes. Yeah. Shireen will probably comment on that.
I do think there was a bit of bias in that because of lockdown, we weren't able to travel anywhere. So we were only able to interact with mostly people who lived in Tauranga and Hamilton. So, and, you know, and even then we, in each category, and there were, 5 categories, we only interviewed about 5 people. That's not exactly representative of the 5 million people that live in New Zealand, and certainly not representative of rural towns or coastal towns, or, you know, those opinions could be different, or their experiences would be different. So this is a very small study, and yes, there probably is quite different to the people that we were able to interview who were able to use technology or had someone to support them. And again, those experiences would be potentially quite different to somebody who doesn't use technology, as you know, is at home and doesn't do a lot of interactions, or who knows, a lot of factors.
Thank you, ladies. And I think you've already recognised the potential for limitations, and you very clearly and very transparently stated that as well too. But I think what you have done is you've made an amazing start. We're biased because we're supportive. Maybe that's our bias, but we're really looking forward to, as I said before, the next phase of the research, because I have no doubt that it will benefit us all, and it'll be an exciting opportunity to see what comes next. So thank you both so very much.
Thank you.
Thank you.
So I'm going to call today's webinar and AGM BGM to close. Annika and Shireen, again, thank you very much for joining us and sharing the insights into your research to date. It's going to be really important and really valuable to see the outcome of everything. So for all the attendees, again, thank you very much for attending tonight. And if there have been any questions and answers that we haven't been able to answer so far, we will send this out to you shortly in due course, post the event. And we will just stay in touch. Just in relation to nominations, if you do want to nominate one of your colleagues, please do so. And we'll be sending out the information electronically shortly. Thank you so much, and enjoy the rest of your evening.